Hello friends, in this video we are going to start this topic glycogen, which is very important for PG entrance point of view. One question from glycogen is a must, and in glycogen storage diseases the questions asked are really difficult, but if you are very clear in your concepts then you can solve all these questions, right? So let's get started. Glycogen metabolism occurs in two organs, liver and muscle. Glycogen is stored in liver and muscle. So tell me, by weight glycogen is more in liver and muscle. By weight glycogen is more in liver, and by percentage, if they ask you, by percentage glycogen is more in muscle. What that means, when I say by weight means if I take same weight of liver and same weight of muscle, then it is more obviously in liver, because liver is smaller in size. So any small tissue will be having lots of glycogen stored in it, right? So by weight glycogen is more in liver, but by percentage, if they ask you, that is, if I calculate full body percentage, glycogen is more where, then it is muscle, right? Now glycogen synthesis is known as glycogenesis. This is anabolic pathway. I told you anabolic pathways occur in cytoplasm, right? And glycogen breakdown, that is catabolism, is known as glycogenolysis. It is a catabolic pathway. Normally catabolic pathways occur in mitochondria, but this is an exception, that glycogenolysis is one catabolic pathway which is occurring in cytoplasm. So can I say both the pathways of glycogen occur in cytoplasm, right? And also both the rate limiting enzymes, both RLEs, both rate limiting enzymes of glycogen metabolism are belonging to transferase category, that is EC number 2 category. We'll be doing that later also. Now glycogen is stored in liver and muscle. What is the function of liver glycogen? Function of liver glycogen is to maintain normal blood glucose levels. And what is the function of muscle glycogen? Muscle glycogen will never give this glucose to blood, but muscle glycogen will use this glucose for its own purpose, that is for muscle contraction. Right? For muscle contraction it is used. Now, depending upon that basic point, that glucose transporters, GLUTs are bidirectional, but if it is glucose, it will come out of the cell. If it is glucose 6-phosphate, it cannot come out via GLUT, right? So now you know that liver's glycogen function is to give glucose to blood. So can I say the end product of liver glycogenolysis should come out of liver cell into the blood, so that liver can give this glucose to blood. But end product of muscle glycogenolysis should not come out of muscle cell, because muscle cell has to use it for its own purpose. So tell me, what is the end product of liver glycogenolysis? Yes, end product is free glucose, so that it can come out of liver cell. But the end product in muscle glycogenolysis is glucose 6-phosphate, so that it cannot come out of muscle cell. Muscle has to use it for its own purpose. So see this question now, that if muscle glycogen is used for anaerobic glycolysis, then how many ATPs are obtained? Normally when we do anaerobic glycolysis energetics, then it is 4 minus 2. What is this 4? 4 is substrate level phosphorylation, ATP production. What is this 2? 2 ATP. 1 ATP used at hexokinase step and other ATP used at phosphofructokinase 1, PFK1 step. This is the energetics which we do. But if muscle glycogen is the starting material, I told you the end product of muscle glycogen is not glucose, it is glucose 6-phosphate. Now this glucose 6-phosphate in muscle cell will directly enter into glycolysis. So already phosphorylated glucose is entering into glycolysis. So there is no need of hexokinase enzyme to phosphorylate this glucose. Therefore now the energetics will be 4 minus 1, that is 3 ATPs is the answer to this question. Right? Remember one thing, that in DNA replication, DNA synthesis, the enzyme DNA polymerase cannot start DNA synthesis. It requires a primer, and that primer is RNA primer, right? Primer is never the same thing which is synthesized. It is always something different. Like we are making DNA, but primer uses RNA, right? Similarly, in glycogen synthesis, the enzyme glycogen synthase cannot start glycogen synthesis. It needs a primer, and the name of that primer is glycogenin. Glycogenin is a protein. It is not a carbohydrate. See, we are synthesizing a carbohydrate glycogen, but the primer used is a protein. So I can say glycogenin is a protein required as primer in glycogen synthesis, right? Now let's say start with the pathway. Let's see the diagram. Now on this diagram, I have written glucose here and glycogen here. Now from glucose to glycogen, this is synthesis known as glycogenesis, and the opposite, glycogen to glucose, that is breakdown known as glycogenolysis. I have taken both these on same page because both these pathways occur in cytoplasm, right? And also see in this diagram, this is a circle. It's like left side of the circle is glycogenesis and right side of the circle is glycogenolysis. So let's get started with glycogen synthesis first. We are starting from glucose. So what is the first step? First step is always phosphorylation, glucose to glucose 6-phosphate, phosphorylation by enzyme hexokinase or glucokinase. The next is glucose 6-phosphate to glucose 1-phosphate. Here intramolecular shifting is occurring. Intramolecular shifting enzyme is mutase, right? So from position number 6 to position number 1, phosphate is getting transferred. Now, glucose 1-phosphate is converted to UDP glucose. This is very important thing. UDP glucose is the activated glucose which is formed now. Now, when this activated glucose is formed, now the rate limiting enzyme glycogen synthase can come and can start using this activated glucose for making glycogen. But I told you, glycogen synthase enzyme cannot start, right? So it will be using this glucose for making glycogen, but it cannot start. So what will be happening, that glycogenin primer is there, and this enzyme glycogen synthase is taking glucose from UDP glucose and transferring it on the glycogenin, the primer, right? So can I say this enzyme is just transferring glucose from UDP glucose to the primer? So this enzyme is a transferase. Earlier also I have told you that all the synthases are lyases, but glycogen synthase belongs to EC number 2, that is transferase category. And see the rate limiting enzyme on right hand side. Rate limiting enzyme on right hand side glycogenolysis is glycogen phosphorylase. If you remember, I told you phosphorylase transfers inorganic phosphate, transfers, right? So this is also a transferase. That's why I have already told you this line that both the rate limiting enzymes of glycogen metabolism are transferases, right? Now let's come to glycogen synthase now. Glycogen synthase is adding which bond? It is adding alpha-1,4 bond, that is straight chains of glucose it is making, right? But we also need branch chains. We need to make alpha-1,6 bonds also. So the next enzyme is branching enzyme which will make alpha-1,6 bonds, and the structure formed which is having both alpha-1,4 and 1,6 bonds is known as glycogen, right? So we're done with synthesis. Then coming to breakdown, glycogen breakdown occurs this way. This is a major pathway of glycogen breakdown, but also see there is one minor pathway of glycogenolysis. This minor pathway of glycogenolysis is occurring in lysosomes. I told you major pathway or any major thing of glycogen is occurring in which compartment? It is occurring in cytoplasm. But only this minor pathway of glycogenolysis is occurring in lysosomes, done by enzyme acid maltase, and deficiency of acid maltase is type 2 glycogen storage disease known as Pompey's disease. So can I say that Pompey's disease is the only glycogen storage disease which is a lysosomal storage disease? Because any other disease is going to affect cytoplasm, right? Any other disease of glycogen is going to affect cytoplasm, but only this disease of glycogen will affect lysosomes. So Pompey's disease is the only glycogen storage disease which is a lysosomal storage disease, right? Now let's see the major pathway of glycogenolysis using 3 enzymes: glycogen phosphorylase, which is rate limiting and first enzyme here, then glucan transferase, then debranching enzyme. Let's see how these 3 enzymes are going to break down glycogen. Now let's say this circle is a glucose residue. Here I am making a straight chain. This is a straight chain and this is a branch chain. Glucose residues are joined here like this, right? In this structure there's only one bond which is alpha-1,6 and that is the branch point. This is alpha-1,6 bond, rest all are alpha-1,4 bonds, right? So this is a glycogen I have made. Now here, how glycogenolysis occurs with the help of the 3 enzymes, let's see that. So the first enzyme which is going to start breakdown of glycogen, that is rate limiting enzyme also, and the name of that enzyme is glycogen phosphorylase. This glycogen phosphorylase, it has a property of transfer of inorganic phosphate, and this enzyme is going to start breakdown. This enzyme will start the breakdown from here like this. It is breaking the bond, then this, like that. It is breaking the bond. So which bond it is breaking? All these are alpha 1,4 bonds. So it is breaking alpha 1,4 bond here, and glycogen phosphorylase it is breaking the glucose residues starting from one end, but it can break only till this point when 4 glucose residues are left at the branch point. Let's say I have a big rod. I'm breaking the rod like this I'm breaking. When the rod is short, then further I cannot break, right? So similarly, glycogen phosphorylase starts breaking glucose residue from one end, but it can break only till this point when 4 glucose residues are left at the branch point, right? And all these glucose which are released, they are given inorganic phosphate also, so that the end product which we get is glucose 1-phosphate end product we are getting. Now the next enzyme is glucan transferase. So second enzyme, glucan transferase, comes here. See, this is also a transferase. Glucan transferase will transfer these 3 residues. It will transfer these 3 residues to the neighboring straight chain. No glucose is released by this enzyme. But can I say, after the action of glucan transferase, our branching point is exposed? The branching point is exposed so that the third enzyme, debranching enzyme, can come and can break this last bond. And this last bond on this branch chain is alpha 1,6 bond. And this enzyme is not having any property of transfer of phosphate. So this enzyme will release this glucose as free glucose. So we have 2 end products, glucose and glucose 1-phosphate. Which do you think in the end is more, glucose or glucose 1-phosphate? Yes, obviously glucose 1-phosphate will be more in the end. In percentage, this is 90%, and this free glucose is just 10%. So can I say that glycogen phosphorylase enzyme is releasing 90% of glucose in the form of glucose 1-phosphate, and on the other hand, debranching enzyme is releasing glucose in the form of free glucose, which in the end is just 10%, right? And also let me tell you, these 2 enzymes, debranching enzyme and glucan transferase, they have bifunctional activity, means same protein is having these 2 enzymatic activities, right? But you know that glucan transferase is not releasing any glucose, right? Now one more also frequently asked question here is, glycogen phosphorylase will use which vitamin or which coenzyme? That is vitamin B6 pyridoxal phosphate is used by this enzyme, right? So what is the major end product of glycogenolysis? Major end product is glucose 1-phosphate. So in the chart now I'm going to write glucose 1-phosphate in the end. See here in the end of glycogenolysis we have written glucose 1-phosphate because this is the major end product. Now glucose 1-phosphate will be converted to glucose 6-phosphate with the help of same enzyme mutase. So I can say this mutase is common to both pathways, glycogenesis and glycogenolysis, and the full name of this mutase is phosphoglucomutase. If you remember, we have done one mutase in glycolysis also, but that mutase of glycolysis is phosphoglyceromutase. So be careful what is given, phosphoglycero or phosphoglucomutase, right? Now we have reached till this point, glucose 6-phosphate is formed. Can I say that muscle glycogenolysis is finished at this point? Because the end product of glycogenolysis in muscles is glucose 6-phosphate, right? But in liver, one more extra step will occur, glucose 6-phosphate to glucose formation done by enzyme glucose 6-phosphatase. So can I say glucose 6-phosphatase is present only in liver and not in muscles, right? That's why muscles cannot maintain blood glucose levels, because of this enzyme absent in muscles, glucose 6-phosphatase is absent. And let me also tell you, this glucose 6-phosphatase is also involved in gluconeogenesis. We have done that. So this enzyme is common to both the pathways gluconeogenesis and glycogenolysis, and this enzyme is present in the membrane of endoplasmic reticulum, right? Now also tell me which enzyme is common between glycolysis and glycogenesis. See, the first step was same in both the pathways, that is exokinase glucokinase step. That enzyme is common in both the pathways, glycolysis and glycogenesis. Okay, now coming to glycogen storage diseases. Just on this chart I have written diseases, just see them once. Type 1 is von Gurk's deficiency of glucose 6-phosphatase. Type 2 is Pompey's deficiency of acid maltase. Type 3 is debranching enzyme deficiency known as Cory's disease or Forbes disease or limit dextrinosis. Then type 4 is Anderson disease, deficiency of branching enzyme. And type 5 and 6, McArdle's and Hers. Type 5 is only in muscle, type 6 is only in liver, and this is deficiency of enzyme glycogen phosphorylase, which is the rate limiting enzyme of glycogenolysis, right? Now just tell me one thing, that most of the diseases are lying on left side or right side? Most of the diseases are lying on right hand side. That is, mostly it is defect in glycogenolysis. That's why they are known as glycogen storage diseases. That is, most of the time glycogen is not broken down, so glycogen gets stored, right? Now, if it is a liver glycogen storage disease, then the main clinical feature of the patient will be hypoglycemia, because function of liver glycogen is to give glucose to blood, and that is not done now. And if it is a muscle glycogen storage disease, then patient will be having muscle cramps and exercise intolerance, because the main function of muscle glycogen is for muscle contraction, right? So that is not done now. Now let's see this table. Which type of glycogen storage disease? The name of disease, enzyme deficient, which organ affected? Type 1 is von Gurk's disease, and also this is the most common glycogen storage disease. And the enzyme deficient, is glucose 6-phosphatase. So which organ will be affected? Liver, muscle, or both? The organ affected is only liver, because normally also this enzyme is not present in muscles. Now next is Pompey's disease, which is affecting lysosomes. Enzyme deficient, I told you, is acid maltase. These three glycogen storage diseases, that is type 2, 3 and 4, I'm going to take together. Type 3 is Cory's disease, also known as limit dextrinosis. Type 4 is Anderson disease, also known as amylopectinosis. In type 3, Cory's disease. C for Cory's, D for debranching, A for Anderson, B for branching. So in Cory's disease, debranching enzyme is deficient. In Anderson disease, branching enzyme is deficient. So it's easy to learn C, D, A, B, right? Now these three diseases, type 2, 3, 4, they affect all the organs wherever glycogen is stored. That is liver also, muscle also, and brain also. So one trick for question solving I will give you. Whenever they give you a clinical picture that liver, muscle and brain all are affected, then you are very sure either it is type 2, 3 or 4. Now if in this question in these clinical features, if they write lysosomes are affected, then you are very sure it is type 2. If they write limit dextrins, then you are very sure it is type 3. If they write amylopectins, then you are very sure it is type 4 which is affected, right? Now coming to type 5, McArdle's disease, in which muscle phosphorylase is deficient and organ affected will be muscle. And type 6, Hers disease, in which liver phosphorylase is affected and organ affected will be only liver here, right? Now, again one thing for question solving I will tell you, if they give you a clinical picture where only muscle is affected, then you're very sure it is McArdle's disease. And there is one confirmatory diagnostic point also for McArdle's disease, that these patients have lactate normal after exercise. So if this thing written in the question, then you're very sure it is McArdle's disease, because in a normal person, when a normal person will do exercise, then lactate levels will be increased because of Cory's cycle. But in this patient, the very first enzyme of glycogen breakdown in muscles is not there. So glycogen is not broken down, glucose not released, and lactate not formed, right? Now if they give you a question that only liver is affected, then either it is type 1 or it is type 6. Now how to distinguish between these two types? Let's see how. We have to distinguish between type 1 and type 6. Type 1 is von Gurk's disease. In this, enzyme deficient is glucose 6-phosphatase, and in type 6, Hers disease, the enzyme deficient is liver glycogen phosphorylase. Now in both patients, hypoglycemia is occurring. I told you whenever liver affected, then hypoglycemia occurs. In both patients, hypoglycemia occurring. Why hypoglycemia is occurring? Because there is no glycogenolysis in both these cases. Both these diseases are defect in glycogenolysis. Now, glycogen cannot give glucose in these patients. Now, I told you whenever body cannot use glycogen or body is not having glycogen, then body depends on a pathway gluconeogenesis for obtaining blood glucose. And this pathway, gluconeogenesis, cannot occur in type 1 patient because this enzyme glucose 6-phosphatase is common enzyme to both these pathways. When blood glucose is not coming from both the pathways, glycogen also and gluconeogenesis also, then these patients have severe hypoglycemia, and whenever severe hypoglycemia occurs, then ketosis occurs. So these patients have severe hypoglycemia and ketosis, but in type 6 Hirsch disease, gluconeogenesis can occur because glucose 6-phosphatase is fine. So gluconeogenesis can occur and these patients can get some glucose. So the hypoglycemia in these patients is mild hypoglycemia, and when mild hypoglycemia, then ketosis will not occur. So this way you can distinguish between these two patients, where in both these cases only liver is affected, right? Now von Gog's disease, which is most common glycogen storage disease, von Gog's disease, most common glycogen storage disease, the clinical features are what? See, in this, what is happening? Glucose 6-phosphate to glucose reaction, this was occurring by enzyme glucose 6-phosphatase. Now this step is not occurring, so this product glucose is not formed, and the substrate glucose 6-phosphate will accumulate, and this whole thing is happening in liver. When glucose is not released in liver, then this glucose from liver is not coming to blood, then these patients have severe hypoglycemia, they have ketosis. When this excess glucose 6-phosphate is getting accumulated in liver cell, then liver cell will think that it is fed state. In fed state, glucose 6-phosphate present and that is converted to glycogen. So liver cell will start making lots of glycogen, and slowly glycogen deposits will occur in liver, and this will lead to massive hepatomegaly in these patients. And now this excess glucose 6-phosphate will be converted to pyruvate, then acetyl-CoA. Then acetyl-CoA will form triglycerides. So these patients have hypertriglyceridemia, and also excess pyruvate will form excess lactate. So these patients also have lactic acidosis, and these patients also have hyperuricemia. I told you whenever lactic acidosis, then hyperuricemia will occur, right? And also kidneys are enlarged in these patients, but spleen is not enlarged. See, I have written hepatomegaly, not hepatosplenomegaly, but kidneys are found to be enlarged in these patients, right? All these clinical features of von Gog's disease are very important, and the most important here is these patients have severe hypoglycemia, right? And also in von Gog's disease, patients have doll-like faces, doll-like or moon-like faces, due to fat deposition. And now tell me, what will be the treatment of von Gog's disease? Treatment of von Gog's disease. See, the main problem in these patients is severe hypoglycemia. Okay, I told you blood glucose comes either from food. When food is not available, it will be coming from liver glycogen. When liver glycogen is not available, it will be taken from the pathway gluconeogenesis, which will occur. But in these patients, glycogen breakdown also cannot occur in liver. Gluconeogenesis also cannot occur, right? So what will happen, that these patients can get their glucose only from food. So these patients should be given small frequent meals, and cornstarch diet can be given, which can give glucose for a longer period of time, right? Now sometimes in some of the questions asked in glycogen, there can be confusion between type 1 disease and type 3 disease, that is von Gog's and Cory's disease, because some patients of type 3, muscle is not affected. So muscle may or may not be affected. If muscle is affected, then CK enzyme will be increased in these patients, right? So sometimes you may get confused between type 1 and type 3 also. So let's do the differences between type 1 and type 3. In type 1 patients, there is hepatomegaly. Type 1 also, only liver is, type 1 also nahi bolna. In type 1, liver is affected. In type 3, some of the patients, if muscle is not affected, then only liver will be affected, right? But these patients usually have hepatosplenomegaly, right? Then there is lactic acidosis in type 1 patients, which does not occur in type 3 patients. In type 1 patients, there will be severe hypoglycemia, but in type 3 patients, usually these patients have mild hypoglycemia or early morning hypoglycemia. Then kidneys are enlarged in type 1 patients, but kidneys not enlarged in type 3 patients. Then the glycogen hepatomegaly occurs in both patients. The glycogen which is accumulated in type 1 patient is normal glycogen structure. The normal glycogen is getting accumulated, but in type 3 patients, limit dextrins are accumulated, which have alpha 1 6 bonds mainly, right? Then if glucagon is given to these patients, both patients have hypoglycemia, right? If glucagon is given, glucagon is hormone which increases blood glucose, right? Now, if glucagon is given in patients of type 1, then blood glucose will not rise. Blood glucose will not rise. But in type 3 patients, if hormone glucagon is given in fed state and in fasting state. If it is given in fed state, then blood glucose will be increased. But if it is given in fasting state, then blood glucose will not be increased, right? So these are the differences between type 1 and type 3, and you can distinguish the two questions which are frequently asked. And in both these patients, what is common? Both these patients, common thing is hypoglycemia, enlarged liver, that is hepatomegaly, and hyperlipidemia or hypertriglyceridemia, right? Then type 2 Pompey's disease. In type 2 Pompey's disease, muscle is also affected, liver is also affected. When muscles are affected, both skeletal muscles and cardiac muscles affected. So these patients have hypotonia. Usually the clinical picture is like a floppy child, limbs lying loose in position in a frog-like manner, okay, due to this hypotonia. Cardiac muscles also affected, leading to cardiomegaly, and these patients have hypoglycemia and hepatomegaly. So with this, you can diagnose these patients. Then note down that most common glycogen storage disease in children is type 1, but most common glycogen storage disease in adults is type 5, right? Now we have to do the regulation of glycogen. I will try to make regulation very easy for you. See, you know that formula that in fed state, insulin is there. Insulin will cause dephosphorylation. So by doing dephosphorylation in fed state, insulin will activate the anabolic pathway, glycogen synthesis. So this glycogen synthase enzyme is activated by insulin by causing dephosphorylation. On the other hand, in fasting situation, enzyme glucagon will activate will do phosphorylation. It will do phosphorylation by activating enzyme, which is the rate limiting enzyme of glycogenolysis. It is glycogen phosphorylase, right? So this is the regulation. I will also make a chart of reciprocal regulation here. Now see here, I have written glycogen here and I have written glucose here. You know, glucose to glycogen is synthesis, glycogenesis, and on the other hand, glycogen to glucose is breakdown, that is glycogenolysis. The main enzyme on left hand side is glycogen synthase, which is anabolic enzyme, and any anabolic enzyme is active in dephosphorylated state. On the other hand, here we have glycogen phosphorylase enzyme, which is catabolic enzyme. So it is active in phosphorylated state, right? Now on this I will apply fasting situation and fed situation. In fasting situation, hormone glucagon will be activated. Glucagon will activate cyclic AMP. Cyclic AMP will cause phosphorylation, and at this point of time in the body, all the enzymes will be phosphorylated. Glycogen synthase is also phosphorylated. Glycogen phosphorylase is also phosphorylated. When this enzyme is phosphorylated, it will be inactive. And when this enzyme is phosphorylated, it will be active. This is what you want in fasting state. In fasting state, you want glycogenolysis to be activated, but on the other hand, you also want glycogen synthesis to be inhibited, right? So we are done for fasting state. Now, exact opposite of this we will be doing for fed state. So the basic thing I am making same. Here glycogen, here glucose. Glucose to glycogen, main enzyme, glycogen synthase. Glycogen to glucose, main enzyme, glycogen phosphorylase. Glycogen synthase is anabolic enzyme. So this enzyme is active in dephosphorylated state. Glycogen phosphorylase is catabolic enzyme. So this enzyme is active in phosphorylated state. So similar kind of thing I have already made. Now we will be applying fed situation. In fed state, hormone is insulin. Insulin will decrease cyclic AMP, and insulin causes dephosphorylation. So at this point of time in body, all the hormones will be dephosphorylated. Now when glycogen synthase is dephosphorylated, it is active. When glycogen phosphorylase is dephosphorylated, it will be inactive, right? This is what you want in fasting. This is what you want in fed situation, that in fed state you want glycogenesis to occur, but you also want that glycogenolysis should be inhibited, right? This is the way regulation of glycogen you can learn very easily. Now see one more thing in glycogen. This enzyme glycogen phosphorylase, this is rate limiting enzyme, catabolic enzyme of glycogenolysis. This enzyme is having two forms, small b and small a. Small b is inactive, small a is active. So how can you convert b to a? How can you convert b to a? By doing phosphorylation. By doing phosphorylation, we can make this enzyme active because it is catabolic enzyme. Any catabolic enzyme is active in phosphorylated state, right? Now we have to learn the activators of this enzyme and inhibitors of this enzyme. First activator written is cyclic AMP. It will cause phosphorylation and activation. Then I told you hormones which cause phosphorylation are glucagon, epinephrine, norepinephrine. They will also cause phosphorylation. Then calcium and calmodulin, they work together and they will activate this enzyme without doing phosphorylation. They can directly activate the enzyme, right? And the last one written is 5-AMP. This 5-AMP they have recently added in the list of activator. The mechanism how 5-AMP is activating, that is not known, right? So just cram this last one, okay? Now we have to do the inhibitors. First is phosphatase, removal of phosphate, so dephosphorylation and inactivation. Again insulin causing dephosphorylation and inactivation. Then next three are a kind of product inhibition. You know what is a product of glycogenolysis? Product is glucose, glucose 6-phosphate and energy, ATP. When we have enough of glucose and energy, then glycogenolysis is not required. That is inhibited. Product inhibition or feedback inhibition, right? The next is last one, very important, fructose 1-phosphate. It is the inhibitor of glycogenolysis. And let me tell you one clinical point, that fructose 1-phosphate is inhibited in a, not inhibited, it is increased in a disease that is hereditary fructose intolerance. It is accumulated in liver in hereditary fructose intolerance. So can I say in hereditary fructose intolerance, the patients will be having hypoglycemia because this fructose 1-phosphate will inhibit liver glycogenolysis. So glucose not released into blood, so hypoglycemia will be occurring. This point is very, very important, right?